Hello and welcome back to the channel. In this video, I want to share an overview of how we approach management of heart failure in primary care. What is heart failure? It is a functional inability of the heart to meet the demands of the body during exercise and at rest. Acute heart failure is the leading cause of hospital admission in people aged 65 and over here in the UK, and over 67,000 admissions annually are recorded in England and Wales. And you are more likely to see a high prevalence of heart failure among those attending for review of long-term conditions like diabetes, and as well as hypertension and chronic kidney disease. Patients who are also obese or smoke or drink alcohol excessively or have had previous myocardial infarction are equally in the high risk group. So the primary care team are therefore in an ideal position to identify the early signs and symptoms of heart failure. In patients most at risk, simple questions can elicit responses that could suggest early symptoms of heart failure. You can ask patients if they have noticed getting more out of breath recently, particularly on exertion, or getting fatigued with little effort. Patients can also report swelling, particularly in their feet, or gaining weight rapidly as a result of fluid retention. You can also ask about cough or palpitations, and getting an ECG if there's palpitations can equally be useful. So if you suspect heart failure, the first thing to do is to request a blood test we call NT-pro-BNP, which is a simple blood test to measure a type of natriuretic peptide that is elevated in heart failure. NT-pro-BNP testing in primary care can help us to rule out heart failure or indicate that further assessment is needed. There are 3 different NT-pro-BNP test result thresholds that can inform which action that can be taken. If the levels are under 400, heart failure is unlikely and no referral is needed. Usually we would say to consider all the causes for the patient's symptoms. If the levels are between 400 and 2000, the advice is for you to refer for a direct access echocardiogram and an assessment by a specialist to be completed within 6 weeks. If the levels are above 2000, then you have to refer similarly to a specialist, but the assessment has to be completed within 2 weeks. Once a patient has been diagnosed with heart failure, the main concern are that these patients are at high risk of hospitalization and death. So an aggressive medical management is now the norm, with the combination of medication that we use to help us achieve this as dramatically as we can within the first couple of years of diagnosis. Early in the 2000s, when I started medical school, we used to only prescribe diuretics like furosemide and spironolactone, the water tablets. And then we also used to add neurohormonal axis modulators, angiotensin-converting enzyme inhibitors like ramipril, and later on, digoxin to improve the pumping ability of the heart. However, just before I finished med school, there was some wavering around the role of beta blockers, but this has now become standard therapy. Bisoprolol, carvedilol, and sustained release metoprolol have now been widely studied in large clinical trials, and these 3 medications all reduce mortality rates in patients with heart failure with reduced ejection fraction. Today, we have 2 additional options to consider. One is the angiotensin receptor neprilysin inhibitors, a combination drug, and also another good class of drugs called the SGLT2 inhibitors, which is a sodium glucose co-transporter 2 inhibitor. This latter drug you might be familiar with when you're treating patients who have diabetes. Some of the researches that I looked at in one called Paradigm HF, it showed that the combination of the sacubutril and valsartan was superior to single angiotensin converting inhibitors, enalapril, in reducing the risk of hospitalization on all-cause death, and this translates to number needed to treat of 21, and for all-cause mortality, number needed to treat of 36. We'll come back to how to interpret number needed to treat later. Similarly, in the DAPA heart failure trial, where they tested the SGLT2 inhibitors against standard treatments, over the median of about 18 months, the total number of people needed to treat with DAPA to prevent 1 experiencing an episode of fatal or non-fatal worsening of heart failure was 16. That's why the current guidelines now recommend a comprehensive 4-pillar strategy for heart failure with reduced ejection fraction. Medication from the following classes should be added and titrated to maximum tolerable doses to achieve the desired effect, ideally within the first 3 months of diagnosis. And the classes of medication are the renin-angiotensin system inhibition with either the ARNIs or the ACEIs or the ARBs. The second class is the beta blockers. The third class is the mineralocorticoid receptor antagonists like spironolactone or eplerenone. And the fourth class now included is the sodium glucose cotransporter 2 inhibitors. This combination can add over 6 additional years of lifespan for heart failure patients with reduced ejection fraction compared to traditional approach of the renin-angiotensin system inhibitors and beta blockers alone. So when you look at comparative medical treatments and their corresponding number needed to treat, you can see why there's a push to optimize patient outcomes using these 4 medicines. The higher the NNT, the more people you would need to receive the medication for one person to benefit. But there's no way of knowing who that person will be. For example, when you're prescribing a statin for secondary prevention with an NNT of 15 to 56 or dual antiplatelets after myocardial infarction with an NNT of 40 to 48, remember that the comparative heart failure treatment has NNT of 11 to 31. So it is indeed an effective combination of medication. So for Mrs. K, who is 70 years old with history of diabetes and hypertension and has been diagnosed with heart failure with reduced ejection fraction, use the 4 pillars as quickly as possible. If there's preserved ejection fraction, she can still benefit from being offered a mineralocorticoid receptor antagonist and a SGLT2 inhibitor. You can bring in the diuretics to manage any cases of fluid overload when it occurs. So overall, this should tie in with the discussions about advanced care planning. Typically, organ failure like heart failure follows predictable dips and general decline over time, and the patient journey along this line should be supported. Advanced care planning discussions should be triggered if there's a progression to advanced heart failure. So these are patients with New York Heart Association stage 3 or 4, worsening symptoms like shortness of breath at rest or minimal exertion despite optimal heart failure therapy. And or if you notice your patients are being repeatedly admitted with heart failure as evidenced by maybe 3 admissions in 6 months, or even if it's a single admission for any patient age 75, it should be prompted to bring these patients in for advanced care planning because there's a 50% 1-year mortality in this cohort of patients. So based on what the data shows, heart failure treatment provides absolute risk reductions that match or exceed even our best established secondary prevention therapies. When we use all 4 pillars together, we can deliver some of the most powerful interventions in our cardiovascular medicine repertoire in primary care. So thanks for watching, and if video has changed how you think about heart failure management, hit the like button and subscribe for more system thinking based learning in primary care.